we are going to change gears again here. I'm going to talk a little bit about something that may be emerging more than here now, but something you've probably heard about, opportunistic screening using body composition measures at CT. And the reason we're talking about this now is because there's all these explainable AI tools that are making what used to be a very onerous task something we can do immediately. And in the very near future, I think some of these tools are going to be at your disposal, and I think patients and hopefully referring providers will be asking for this kind of information. We have to be at least ready to provide it, and if we don't do it, I think someone else will. So that's another thing. I think it actually makes a lot of business sense to be willing to run with this. So I'll explain a little bit more about what I mean by all of this. So what is opportunistic CT screening? Basically what I'm talking about is leveraging all this information in a CT scan. We're going to focus on abdominal CT, but it really applies to chest CT as well, and even other parts of the body, but mainly body imaging. So it's using all this extra information that goes well beyond the reason the scan was done. So for example, if you had a scan in the ER for diverticulitis, left lower quadrant pain, obviously, CT is very good for making that call, yes or no, rule in or rule out. But there's a lot of other things that we're just ignoring. And a lot of that, I think, can really become part of a virtual physical exam. So it's really getting more value out of these scans. Now, I apologize for the term opportunistic screening. Some people take exception to that. It's a term that's obviously existed long before imaging. But the fact that it was in use, and I think it's here to stay. Obviously, we can also talk about just value-added imaging or incidental imaging. It doesn't quite get at the root of it, but I don't think there's any way around it. We're going to be using this term one way or the other. Why are we talking about it now? Well, I think with body CT imaging in general, because it's such a good, objective, reproducible, generalizable tool, that is, we're taking scans that are done even decades earlier and comparing them to scans we do today on a different vendor, maybe a vendor that doesn't even exist anymore, and they're quite comparable. So this is unlike ultrasound and MR. I think you're going to have a lot more problems between vendors and between imaging sequences and such. And we do a lot of body CT. There's over 100 million done each year in the US, especially if you're including both abdomen and chest, and nearly 100, probably about 75 to 80 million abdominal CTs. On average, every adult over 60 has had at least one or two scans on average. Of course, many have more than one, and so some people obviously haven't been scanned yet, but the volume is definitely there to justify this. And now that we have these explainable AI tools that can take care of the task of painful measurements, I think it's going to make life a lot easier, and it really gets to this personalized medicine and adding value. There's a lot of opportunities here. Here's just a kind of a list of some of the main things, and I'm just going to focus more on what I would call cardiometabolic composition, body composition measures. So we're looking for things like, we kind of started out with osteoporosis, cardiovascular disease, sarcopenia, metabolic syndrome, and so forth. There's a lot of opportunity here. And so I'm going to be kind of using our own case example of the tools we have in our pipeline, but they're pretty analogous to a lot of other tools that are either available or soon to be available in the clinical realm, certainly available in the research realm. I became interested in this probably about a decade or so ago, but now, as I mentioned with AI, it's become more of greater and broader interest. These are just a couple of recent articles that we came out with just to try to explain what we mean by the concept and where we think it's going. And I'm going to use a case example. So this is, this could have been a patient, as I mentioned, with left lower quadrant pain who got imaged to rule out diverticulitis, but this was a outpatient who was getting colorectal cancer screening with virtual colonoscopy, just to use it as an example. And it's a nice example because non-contrast CT is sort of a good place to start. We can certainly use IV contrast scans for this purpose, but the lack of contrast makes it a little easier. But in general, this patient, so this was done, you can see way back in 2005, it was a negative scan, no polyps. So if this patient had had a colonoscopy, presumably same result, they would have been negative, see you in 10 years or 5 years or what have you. But obviously, there's more to this scan than just the patient's colon, and we've always known that. In fact, that's been a negative, according to CMS, in terms of all these extracolonic findings as a negative. Well, I've always kind of thought, well, maybe the glass is more than half full. Maybe there's some things we can harness here. So just looking at this patient, who obviously has more than just a colon, as radiologists, we've always known that, and we've always responsibly handled all these extracolonic findings, if you will. If there's something that needs workup, we do it. But in the terms of cardiometabolic imaging and fat and muscle and liver and calcium and all these things, we don't have a real good way of reporting other than to say, yes, there's a fatty liver, there's a lot of aortic calcium here. Maybe the bone mineral density is off, but we haven't really been systematically been using that. We'll come back to this patient later on in the talk to see, how he ended up doing. So I'm basically talking about these basic body composition measures: fat, muscle, calcium. We'll throw in liver and certainly bone mineral density. These can all be done and have been done for many years in a manual setting. We still do it manually every day in terms of in terms of bone mineral density. We'll throw a region of interest, usually on the L1 vertebral level, as I'll mention. But, of course, we can measure liver fat on a non-contrast CT as well, and so on and so forth. But we don't really systematically do this to any real degree. We can use these measures that I'm going to be talking about on any body CT. Abdominal, chest, it works well, just the same, but I won't be talking about that. And then if IV contrast was given, we can adjust for that for most of these measures. The only tricky one is the liver, where you can really only categorically place people in categories of mild, no, moderate, or severe steatosis. You really can't quantify it unless maybe with spectral imaging we may be able to do that. And here's an example of what our pipeline currently looks like. So we do all these, these AI tools are pretty basic. They're deep learning tools, but they're doing things that we understand, or they're explainable. So all we have to provide are these QA images. We use the L1 level primarily for bone mineral density. We place this trabecular region of interest right here. The L3 level is usually the standard for measuring visceral and subcutaneous fat, and for muscle as well. So you want to be able to have these two levels. And then we include this coronal MIP because you can at a glance see all the vascular calcification of the abdominal aorta. We can also see if we're doing organ segmentation, we can see if those were segmented appropriately. So therefore, you could say, I can use this liver volume, cut off some of the spleen. So maybe that's not going to be a great case for that, and so forth. So within seconds, I can either approve or reject this case in terms of whether the segmentation was done appropriately. So I'm just going to go through some of these, just real basic stuff on each of these biomarkers and kind of what the value, at least immediately, that we can get from these. This is kind of where it all started for me, at least, was osteoporosis. Obviously, I think we can agree that CT is better than a DEXA scan in terms of evaluating bone mineral density. Unfortunately, we're stuck with that reference standard, so it's hard to prove that when your reference standard is much inferior. But that being the case, we did start out by comparing CT to DEXA. This was now over a decade ago, just doing manual region of interest at that L1 level. And I think you can see here just visually, as we go from someone with normal bone mineral density all the way down to osteoporosis. So once we get under 100, definitely under 90, we're getting into not only osteoporosis, but fracture risk significantly increases at that level. I think with soft tissue windowing, you can really appreciate how just visually you can see how the bone mineral density decreases. And obviously with bone windows, we can evaluate that as well. But this is easily confirmed by putting, usually on the sagittal view, I'll look for fractures and then add a region of interest. We diagnose every single day on body CT. I diagnose several cases of unsuspected or unknown osteoporosis, often complicated by at least one compression fracture. And that's because most osteoporotic compression fractures involve patients with non-osteoporotic DEXA scores. That's always been a known thing, that it's very insensitive for that. And as we age, there is a normal, so we have to, whether we call somebody who's over 90 years of age and is at the osteoporotic level, almost on average, most people will have osteoporosis at that age. So you do have to take it into context of the patient age, whether it's actually normal for age or not. And that's not something we do at DEXA, right? We just use T-scores, which are just comparing to normal young adults. So it's kind of a confusing topic, but just long story short, when people ask what Hounsfield unit measurement matters in that trabecular space, once you hit 90, that's the best level for, in terms of future fracture risk. People below 90 will definitely have a higher rate of fractures. Less than 100, you're already 90% specific to having osteoporosis, but that's just, again, comparing to DEXA. But realize you can't have both sensitivity and specificity. So you can either choose a level that's sensitive and non-specific, or insensitive and specific. So I hope that makes sense. But again, we're comparing to this fallible reference standard. What about aortic calcium? Well, this is something we've been doing for a long time as well. We actually have been using, early on, we did kind of a semi-automated, using the coronary calcium type tools to look at abdominal aortic calcium. And what we found out early on was, even if you just take an Agatston score of somebody's abdominal aorta, these are patients that were asymptomatic outpatients getting a CT colonography screen. That's the cohort we first looked at. By quartile, you can see if you have the higher quartile of aortic calcification, your risk for future cardiovascular event or death is clearly separated out from the other quartiles. And you can see there's much better separation than the Framingham risk score, which is a very complex multivariate measure that actually in the end has more confusion to it than this single now automated measure. I mean, it was semi-automated at that time. Okay, what about visceral and subcutaneous fat? We know about the different distributions between men and women. Women tend to have more subcutaneous fat. Men tend to have more visceral fat. The apple pear sort of thing. But obviously there are exceptions, and those are just generalizations. But we know visceral fat is typically considered the unhealthy metabolic fat. So if you look at these two patients, one has the apple versus the pear shape. That's kind of that analogy doesn't really hold up as much when we look at visceral and subcu fat. But this patient has a lot of visceral fat, and the visceral to subcutaneous ratio is significantly higher than this patient, who, even though is more obese in terms of BMI, has a much more favorable fat profile and distribution, and is at much lower cardiovascular risk than this patient. And that's what really matters, is outcomes. Interestingly, when we look at not only visceral fat area, but the attenuation, so inflammatory fat, we're thinking maybe even mesenteric paniculitis may be essentially metabolic syndrome manifestations in the abdomen. So when you have higher density of that visceral fat and you have a lot of it, this blue line here, your prognosis is much worse than someone who has less visceral fat and or not as dense. So that's kind of a double whammy when you have a lot of visceral fat and it's increased in attenuation. But we're still kind of working out what that all means. In terms of muscle, there's been a lot of work. There's thousands of papers written on sarcopenia. That initially focused on amount of muscle, that is penia, myopenia, and looking at cross-sectional area or volumes. What we've found, though, is a much more valuable biomarker is looking at myosteatosis, that is the density of this skeletal muscle. So we take the L3 level, that's the standard, and you can see there's kind of marbling here in these paraspinal muscles. This is where it really happens, this intermuscular adipose tissue. And then there's also intramuscular lipid as well. So both of those will lower the attenuation. And every time we look at this, and I'll show some examples of our VC population again, it's a very prognostic sign. Nobody knows quite what to do with this. Can we treat sarcopenia and myosteatosis? Do you just need to exercise more, or is it regardless of whether or not we can change the future of somebody with it, we can definitely tell them they're at higher risk for bad outcomes. And these are two patients, both of whom had a virtual colonoscopy, same age basically, both men in their young 50s, exact same BMI essentially. But one has a very healthy fat in terms of muscle density, whereas now in yellow we're kind of coloring all the fatty areas. And this patient has a much worse prognosis. And let me just show you what I mean by that. So if we take, these are just healthy outpatients, looking at no other measurement but just the density of their skeletal muscle. If you're above, and I think this is just the lowest quartile, if you're in the top 3 quartiles, this is what your survival is over 10 to 15 years. If you happen to have less dense, more intermuscular and intramuscular fat, you can see the outcome is much poorer. Compare that with the cross-sectional area, and this is where all the literature was looking at cross-sectional area and amount of muscle. There's a little signal there, but it's nowhere near the signal we get from looking at density. So I think that's kind of where we're focusing our attention. And then looking at BMI, it does even worse, right? It's just not a good predictor because you're not really showing not only where the muscle, the fat is, but you're including muscle in that BMI measurement. So it's it's confusing all those important biomarkers. And so that's why CT and cross-sectional data seem to be much more promising. Lastly, liver attenuation or steatosis. We know this is also a major problem that kind of folds into metabolic syndrome, but also has a separate overlay of NAFLD that we're now calling MASLD, which is metabolic dysfunction associated steatotic liver disease. MASLD is the new term, not over NAFLD, which obviously was not a perfect term to call it non-alcoholic. Really never was a very good descriptor. Anyway, but one thing you should know on a non-contrast CT, the density of the liver in attenuation has a pretty linear correlation with MR-PDFF. I mean, it's not perfect, but this is in the phantom, it's perfect pretty much. Or close to it. But in real life, depending on if you had it done a few days later or a week later, you can obviously change your fat in the liver. Just going on a bender can do it. But when you compare these two, so we can easily say, like, if a patient has a non-contrast CT, and let's say their attenuation is 43, so just above the moderate threshold of 40 equals 15%, but 43 would put you somewhere here, and you could say, somewhere about 12, 13 or whatever, and sure enough, this patient had a 12% PDFF, and so on and so forth. You can pretty much quantify fat on a non-contrast CT pretty well. And again, 40 Hounsfield units, 40.0 luckily equals 15% PDFF, which is generally the threshold for moderate or severe versus mild or none. And I tend to include, I consider kind of mild and none to sort of be in the same category because it's over half our population, whereas 10% of people have moderate steatosis on average. So let's go back to our clinical use scenarios then, or I'm listing them a little differently here. Now we've kind of talked a little bit about cardiovascular disease, osteoporosis, fatty liver, but there's other ways we can apply this. Let me just show you one example. If we look at metabolic syndrome, we know this is a big public health issue. The trouble is the clinical definition is really pretty weak, and it doesn't even include visceral fat specifically or ectopic fat within the liver or muscle. It's really just looking at central obesity and whether you have diabetes or hypertriglyceridemia and cholesterol and so forth. So it's really kind of a crude measure, and I think if we redefine it with our CT measures, I think we're going to have a much better CT-based diagnosis of who really has a metabolic syndrome in terms of poor outcomes. And if we can show CT is much better, maybe this will be one of the preferred diagnosis in the future. If you have a CT scan, I think it's going to be a much more precise definition of who has metabolic syndrome and who doesn't. So let's go back to our about 10,000 patients that had a virtual colonoscopy. This is where we applied our initial efforts. So we ran those people through this pipeline of all these body composition measures, and how did we do, or what was important? I've kind of already hinted at a lot of this. What we did for these papers, we actually took just a single measure of each. So we looked at the visceral, the subcutaneous fat ratio for fat. We just looked at the density for myosteatosis from muscle, looked at the Agatston score for the aorta, just their liver fat quantification, and then bone mineral density, and tried not to make it too confusing. And just to boil this down, for people that after their CT scan, those that died during the ensuing 10 years or so versus not, just looking at average, there was obvious differences between most of these. You can see Agatston score, muscle density, almost a 10 Hounsfield unit difference. And this is just very crude, just looking at means, right? This doesn't really tell the story. But if we look a little more closely at area under the ROC curve, then it starts to get even more interesting. So Framingham risk score did pretty well for predicting survival, and BMI was a coin flip basically. So again, BMI there's a lot of confusion and not a great predictor of outcomes. I'm surprised that it didn't do any better than that, but actually a low BMI can be just as bad as a very high BMI, so there might be some confusion there. But then if we look at just single automated measures of aortic calcium and muscle density, both of those by themselves, again, outperform the Framingham risk score, as we saw kind of earlier. And now if we add a bunch of these things together, like aortic calcification, muscle density, liver density, we can further improve our prediction of who's going to have a bad outcome. And this is kind of the first phase. This is not really getting at the scores. We're going to have more predictive modeling that's going to spit out things like 10-year risks for this or that, or what is your CT biological age, for example. That's something we can do already. And then if we look at this, so again, comparing Framingham risk score, this is in this 10,000 patient cohort, looking at BMI where there's very little signal. You can see these individual measures, all by quartile at least, can separate out pretty well. BMD, it's pretty much if you're in the worst quartile, it separates out from the other three. But the others have fairly good separation in terms of the quartiles and outcomes. Same for liver density. So let's come back to this patient now. So he was, again, he had a negative scan, see you in 5 years, but he didn't look so good in terms of a metabolic syndrome. You can see he's got severe steatosis. He's got a lot of visceral fat relative to his subcutaneous fat, one of the, really taut sort of belly. He's got a lot of aortic calcification for a 52-year-old. So how did he do? He was presumably healthy. His Framingham risk score was low, risk of 10-year event, 5%. He was barely overweight, which is probably lower than average for our population. But he was a metabolic disaster, basically, in terms of his, the amount of visceral fat, liver fat, aortic calcium. And again, this is how we look at it now. But what really happened, so 3 years after that screening exam, he had his first heart attack. 5 years after that, he had a stroke. And then he had a minor trauma in 2017. He had this is just read as a negative scan, no trauma. But I think you can see his calcium's progressing. His liver is even fattier on this post-contrast study. His flanks are bulging with visceral fat. And he died later that year, basically, of metabolic causes, cardiovascular disease. And this is something we could have predicted, based on, what he looked like in this silent pre-symptomatic condition, basically. So CT can kind of uncover some of these risks that I think does a better job than some of the clinical assessment tools. Same thing for fractures. I don't want to go into great detail, but if we look at that L1 trabecular density, and if we add it with, muscle has some complementary input to that, we can beat the FRAX score, which is really the gold standard clinical score. It's 12 predictors that you have to enter into an online calculator to get a 10-year risk for fracture. But just these single CT measures do about the same, actually. So that's very encouraging. And here's just showing that performance again by quartile. Let's look at a case example. This is a 59-year-old. She actually had a perforation at colonoscopy at age 50. So for her follow-up colorectal screening, she had a virtual colonoscopy. And again, this was negative. There was no polyps. Her FRAX score was well below any treatment thresholds of 20% and 3% for hip fracture risk over 10 years. But her bone mineral density, as you can probably see visually, is quite low. It's at 63. So that's well below that 90 Hounsfield unit fracture threshold that we're concerned about. The patient also had significant myosteatosis, was negative in terms of that. 3 months after this scan, she had a catastrophic hip fracture. Well, we could have seen that coming, but we didn't have time to intervene based on the new diagnosis of osteoporosis. But the reason I like this case is this patient actually had a history of urolithiasis, so kidney stones going back 12 years earlier. You can see this patient had multiple non-contrast CTs, which we can directly compare. And when we look at this automated bone mineral density tool, you can see she's really falling off pretty quickly into osteoporosis almost a decade before she had that hip fracture. So we should have known about this. We should have alerted the referring provider that she has, advanced osteoporosis and myosteatosis. So basically, we should have seen that coming. Here's one more example. People ask, well, will people do anything? You can lead a horse to water, but will they actually follow through? If you tell them they have bad markers, will they want to do something about it? Well, this is my virtual colonoscopy, and my numbers are all pretty good. I was pretty happy about all the body compositions. Not ecstatic, but I wasn't too disappointed, except for this. And I have to tell you, I saw, calcification. When you see your own calcification, let alone coronary, I have some bad coronary calcification. So even though I knew I had elevated cholesterol for over a decade, my LDL was high, and I knew that. As soon as I saw this, though, I went to see a preventive cardiologist, got on a statin within a week, and then my next blood draw, you can see now I've lowered my LDL to a third, basically, of what it used to be. So hopefully it's not too late, but I should have done it based on these numbers, but the numbers weren't speaking to me like the images do. So maybe because I'm a radiologist, but I have friends and family where the same thing played out. Once they saw their visceral fat had increased, or you name it, they acted on that information, at least as best they could. So where are we going with this? Just to say, we're doing a large trial, multi-center trial, trying to get over 1 million patients of data to really improve the models and what it all means. We're calling this the OSCAR trial, the Opportunistic Screening Consortium in Abdominal Radiology. We're already developing, we have a biological age. There's other tools that are coming. We already have a tool that looks at liver fibrosis, looks at the pancreas, kidney stone volume. That's sort of a separate thing. It's not really part of these opportunistic biomarkers, but will be, all these tools will be useful. We can apply this to cancer frailty, to pre-transplant modeling, and so forth. So there's a lot of potential ways we can use this data. We really want this eventually in the clinical realm, maybe spit out this is just a crude template of what we came up with. You could tell a patient and their provider where they are for each of these measures relative to their peers, and so forth, and then come up with 10-year risks and biological age and so forth. So we think clinicians, once they see the power of this, they're probably they may start asking for it. There's a lot of challenges to implementation. I don't have time to get into this, but we did enumerate these in a recent publication in Radiology for anyone who's interested. Obviously, we're nowhere near payment models for this in terms of reimbursement. Some things have gotten through the FDA. I didn't even talk about intended screening, but you can imagine if this opportunistic approach is so valuable, well, we could start doing low-dose CT when somebody turns 50, potentially as an intended screen, but let's not go there, kind of getting ahead of ourselves. And then finally, we looked at cost effectiveness, and you'll just have to take my word for it. It's a very complex Markov model, but basically compared to ignoring the information of aortic calcification and bone mineral density, it was cost savings just to find people that were at high risk for fracture or cardiovascular event, put them either on a statin or treat them for osteoporosis, than it was to ignore that data or to simply put everyone on a universal statin therapy. So it was cost savings and clinically efficacious. So it dominated over ignoring them, basically. But you'll have to take my word for it. So in summary, I think this is something that's coming. I think we do a ton of CT. We're only doing more and more because it's such a great test. But there's a lot of information that we could harness. And I think if we do this intelligently, we'll be able to control this and really add a lot to patient care is what I'm hoping, because it's exciting to see how well it can predict and put people in different risk categories. So we'll see in the end if this becomes reality in the next few years, but hopefully. And again, so rather than treat your scanner like a hammer to nail the diagnosis, I think we should treat it more like a toolbox where we're taking care of the whole patient and not ignoring all that other stuff beyond just the reason for the scan alone. So with that, I thank you for your attention, and thank you.